Hello everyone. Today we are going to learn about the important chapter from the Bayesian law, that is shock. So in this chapter we are going to cover about the basic pathophysiology of the shock at the cellular level, the pathophysiology at the microvascular level, and the pathophysiology behind the systemic manifestation of the shock. So there are many questions asked regarding the shock. It can be a basic pathophysiology, classification of the shock, or it can be a long answer question regarding the different types of shock and the manifestation of the hypovolemic, or it can be a question on the septic shock. So in this chapter we are going to learn about the basic pathophysiology of the shock, clinical manifestation of the shock, and the regarding the hypovolemic shock, that is the most common type of shock, that is hypovolemic shock. So let's start with the definition of the shock. So by the definition given in the Bayesian law, shock is a systemic state of a low tissue perfusion that is inadequate for the normal cellular respiration. So this is the short and crisp definition given in the Bayesian law. The more descriptive definition given by the SRP, it states that it is a state of cellular and a tissue hypoxia with either reduced O2 delivery or a poor O2 utilization or a increased O2 consumption with a cellular failure and the poor perfusions. That is a more descriptive definition which includes the pathophysiology of both cardiogenic as well as hypovolemic and the septic shock. So basically during the state of shock, there is a reduced O2 and the glucose concentration at the cellular level. So from the cellular level, the aerobic respiration is converted into the anaerobic metabolism. So because of this, there is a production of the lactic acid. So this may be a cause for a metabolic acidosis in the case of a shock. As well as there is a lysosomes are released into the blood, and which causes the cell lysis and ultimately lead to the death of the cell. And because of the reduced oxygen concentration, there is a free radical injury to the cell with combination with the release of the multiple cytokines and the metabolic mediators, which ultimately lead to the cell death. So let's see what is the pathophysiology of the shock, the cellular level, the microvascular level, and at the systemic level. So let's see the pathophysiology at the cellular level. So because of the shock, there is a reduced blood supply to the tissue or a cell, which ultimately result in a decreased blood glucose level at the level of the cell, which causes the stoppage of the aerobic respiration, and there is a decreased production of the ATP. So at the cellular level, there is a reduced amount of the ATP. ATP is the energy source for the cell, and it will causes dysfunction of the sodium and potassium pump. This is a cell membrane pump which is normally responsible for the efflux of the sodium and the influx of the potassium. So because of the dysfunction in the sodium potassium ATPase pump, there is a increased concentration of intracellular concentration of sodium inside the cell. Because of the increase in intracellular concentration of the sodium, there is a hyperosmolarity inside the cell. So because of this, water gets absorbed into the cell, which ultimately causes the edema of the cell. So because of the sodium potassium pump failure, there is a increased intracellular accumulation of the fluid, and this is the first sign of a cell death, which ultimately result in the release of the autodigestive enzymes by the lysosomes, and ultimately really causes the cell death. So the death of the cell occurs is mediated by the lysosome. So it is a lysosomal cell death, and ultimately the cell lysis, which result it into the concentration of the potassium inside the cell is released into the circulation because of the cell lysis, which ultimately lead to the formation of the hyperkalemia. So because of there is a increase release of the potassium from the cell after the cell death, it will result into the hyperkalemia. And because of the failure of the ATPase sodium potassium pump, there is a hyponatremia as well as there is a hypercalcemia, because at the cellular level sodium and calcium goes inside the cell, and after the lysis the potassium released into the circulation, which ultimately lead to the formation of a hyperkalemia. So at the cellular level, the changes which occurs are, one is hyperkalemia, another is hyponatremia, and another is a hypocalcemia. These are the changes or the pathophysiology at the cellular level. So what happens at the microvascular level? So let's see the changes at the microvascular level. So because of the shock, there is a hypoxia and acidosis. Why acidosis? Because of the aerobic respiration is converted into the anaerobic respiration, and ultimate product of the anaerobic respiration is the lactic acid. Because of this, there is a lactic acidosis at the cellular level. So there is a hypoxia and there is a acidosis, which ultimately causes the stimulate the complement system and also stimulate the leukocytes, which causes release of the free radicals and the cytokines, which causes ultimately leading to the capillary endothelial injury. So there is a injury to the capillary endothelium which causes vasoconstriction. Initially we have learned in the chapter of wound healing, after injury or a trauma, the initial response by the endothelial cell is reflux vasoconstriction and ultimately lead to the vasodilatation. Because of the vasodilatation, there is a formation of the leaky endothelium, or there is a formation of the endothelial gap junction, which causes a release of the fluid from the intravascular compartment into the extravascular compartment, and which ultimately lead to the formation of the tissue edema. So this is the pathophysiology at the microvascular level. So ultimately this will result into the systemic manifestation of the shock. So let's see the systemic manifestation of the shock. So because of any type of shock, there is a decrease in the preload and the afterload. Because of the, it can be because of the decrease volume in hypovolemic shock, or it may be due to decrease cardiac output because of the cardiogenic shock. Whatever may be the cause, there is a decrease in the preload and afterload, which ultimately stimulate the baroreceptor, which are located at the arch of aorta and the carotid artery. So there is a stimulation of the baroreceptor, which causes increased sympathetic activity as well as increased release of the catecholamines in the circulation. So because of this, there is an increase in the heart rate and there is a systemic vasoconstriction. So these are the effect on the cardiovascular system. It causes tachycardia and the increase in the systemic vascular resistance, which causes systemic vascular increase in systemic vascular pressure, that is systemic vasoconstriction. But this effect is exception for this is for the vasoconstriction is a septic shock. So basic pathophysiology in the septic shock is that there is a systemic vasodilatation and the pulling of the blood into the vascular system. So the systemic vasoconstriction is not occur in the septic shock, but the septic shock lead to the formation, or systemic vasodilation lead to the formation of the septic shock. The exception for the tachycardia is a neurogenic shock. In neurogenic shock, there is a bradycardia. So the shock with bradycardia is a neurogenic shock. The shock with the systemic vasodilatation is a septic shock. So remember this. So because of the release of the catecholamines and metabolic acidosis, so there is an increase in the respiratory rate. So because of the metabolic acidosis, there is a respiratory compensatory mechanism start, and it will causes increase in the respiratory rate to to act against the metabolic acidosis by uh, uh, dewashing the dewashing the carbon oxide from the lungs. So there is an increase in the respiratory rate and there is an increase in the minute ventilation. So this is a compensatory respiratory alkalosis. So these are the effect on the respiratory system. So because of the decreased cardiac output or shock at the cellular level, there is a hypoxia which causes release of the cellular metabolite and the formation of the lactic acidosis, which ultimately lead to the metabolic acidosis. For the compensation of the metabolic acidosis, there is a respiratory alkalosis by increasing the respiratory rate. So let's see the effect on the renal system. So because of the decreased cardiac output due to shock, ultimately the blood supply to the renal system is also going to be decreased. So it will lead to the decreased GFR and the decreased urine output. So because of this, there is an activation of the renin, aldosterone, angiotensin system, which ultimately lead to the vasoconstriction and sodium and water retention. So effect on the renal system could be decreased GFR or decreased urine output, and ultimately it will lead to the activation of the renin angiotensin system, and this causes the vasoconstriction and sodium and water retention. So because of the increased sodium and water retention, there is also stimulation of the antidiuretic hormone, which causes further concentration of the urine, which ultimately lead to the decreased urine output. So this could be the manifestation of the shock, low urine output. So at the same time, there is activation of the platelet, which causes activation of the coagulation cascade and lead to the formation of the multiple coagulation cascades at the tissue level or at the site of the intravascular compartment, and formation of the multiple coagulation pathways leading to the disseminated intravascular coagulopathy. Why? Because of there is a consumptive coagulopathy which causes platelet dysfunction, as well as all the clotting factors are exhausted. So ultimately lead to the disseminated intravascular coagulopathy, and because of this, there is it lost the function of the coagulation, because all the coagulation factors are utilized and lead to the further bleeding, and this ultimately lead to increased bleeding and will increase the severity of the shock because of the increased blood loss. And so the activation of renin-angiotensin system and the stimulation of the ADH hormone, this contributes to the manifestation of the endocrine. This is the endocrine manifestation of the shock. So this is all about the systemic manifestation of the shock. So ultimately, so remember that in CVS there is a increased heart rate, there is a systemic vasoconstriction. Exception for the tachycardia is neurogenic shock. In neurogenic shock, the bradycardia. Another effect is a systemic vasoconstriction. Exception for that is a septic shock. In septic shock, there is a systemic vasodilatation. The effect on the respiratory system is increased respiratory rate. It is due to compensatory respiratory alkalosis. The effect on the renal system is that decreased GFR, decreased urine output, and endocrine manifestation are stimulation of the renin-angiotensin system and the stimulation of the ADH, antidiuretic hormone. The antidiuretic hormone is also known as vasopressin, which act at the distal end of the collecting tubules, and it causes increased number of aquaporins, which causes further concentration of the urine by absorbing the water. So this is all about the systemic manifestation of the shock. So up to this, we have learned about the pathophysiology at the cellular level, pathophysiology at the microvascular level, and the pathophysiology at the various system. So let's see the different types of the shock. So basically the shocks, there are 5 types shock. according to the Bayesian law. First is a hemorrhagic shock or a hypovolemic shock. This is the most common. This is the most common type of shock, that is hemorrhagic shock or a hypovolemic shock. Next is a cardiogenic shock. Another is a obstructive shock. There is a fourth one is a distributive shock, and last one is a endocrine shock. So let's see one by one the basic pathology, the examples of the different types of the shock, and how we should differentiate these shock. So let's see the classification of the shock. So one is a hypovolemic shock, another is a cardiogenic shock, another is a obstructive shock, distributive shock, and the endocrine shock. So let's see one by one from the hypovolemic shock. So hypovolemic shock is we all know that it is the most common type of shock. It can be due to hemorrhage. The hemorrhage can be external hemorrhage or internal hemorrhage. It can be due to severe burns, or it can be due to peritonitis or intestinal obstruction, which ultimately lead to the third space volume loss. It can be due to severe dehydration due to vomiting, diarrhea, or it can be due to excessive urinary loss, like in case of a diabetes. So this is the causes for the hemorrhagic shock, that is hypovolemic shock. So another type is the cardiogenic shock. In the cardiogenic shock, the problem is at the pump level, that is at the level of the heart. So basically the volume of the blood is normal, but there is a dysfunction at the level of the heart. The heart is unable to push the blood up to the level of the cell. So the problem is in the pump. So this is because of the primary failure of the heart, that is heart failure. It can be due to acute MI or cardiac arrhythmia, dysarrhythmia, valvular heart disease, blunt myocardial injury, or cardiomyopathy, drug-induced cardiomyopathy, or it can be due to toxemia. So basically the problem is at the heart level. In case of the hypovolemic shock, the problem is that there is a decrease intravascular volume of the blood. But in case of a cardiogenic shock, the volume is normal, but the cardiac pumping activity is reduced. So we are unable to pump the blood at the cellular level, and it will lead to the shock at the cellular level, ultimately leading to the hypoxia and decreased blood glucose concentration at the cellular level. So another type is a obstructive shock. So remember that the obstructive shock, in which there is a volume of the blood is normal, actually the heart is also normal. The problem is that there is a filling defect of the heart because of the obstruction to the preload. So there is a obstruction at the level of the preload. So let's see this by. So by this diagram, so if this is the heart, because there is the blood enter to the heart by IVC or SVC, because of the obstruction at the level of preload, that is the filling defect, the blood is not coming into the heart properly from IVC or SVC. This is going to be because of there is a increased intrathoracic pressure. It can be due to cardiac tamponade, increased intracardiac or intrapleural pressure, or it can be due to tension pneumothorax, or it can be due to massive pulmonary embolism. The cardiac first causes, like it is cardiac tamponade and the tension pneumothorax will causes decreased filling of the right-sided heart. Massive pulmonary embolism will cause decreased filling of the left-sided of the heart. So ultimately leading to the decreased cardiac output. That is, the problem is at the preload, decreased preload because of the decreased filling of the heart. It can be from the right-sided heart, or it can be decreased filling of the left-sided heart. The pulmonary embolism causes decreased filling of the left-sided heart, and the cardiac tamponade at the tension pneumothorax causes the decreased filling in the right-sided heart. So this is the obstructive shock. Another type of shock is a distributive shock. The distributive shock is because the heart is normal. In this shock, the heart is normal. The volume of the blood is also normal. The filling is also normal. The problem is at the cellular level, because there is a problem at the distribution of the blood at the level of tissue or cells. So this is because of the problem in the peripheral vasculature. That is, there is a systemic vasodilatation. So blood remains into the veins or venules, and that does not goes towards the cell. So this is because of the problem in the distribution, that is due to problem at the vascular level. So because of the systemic vasodilatation. So the causes for the distributive shocks are septic shock, anaphylactic shock, or a neurogenic shock, in which there is a increased vasodilatation. The blood remains into the vascular system and does not go towards the cell or a tissue for their metabolism. Another type or the last type is a endocrine shock. It is a combination of, remember, it is a combination of three shocks. One is a hypovolemic shock, another is a cardiogenic shock, and last is a distributive shock. So it is a combination of three shocks: hypovolemic, cardiogenic, and distributive shock. So examples of the endocrine shocks are hypo or hyperthyroidism, or it can be due to adrenal crisis. So because this endocrine effect occurs at different level, it can act at the cardiovascular level, or it can be act at the cellular level. So it is a combination of the hypovolemic plus cardiogenic plus distributive. So this is all about the different types of the shock. So this is the different types of the shock: hypovolemic shock, cardiogenic shock, obstructive shock, distributive shock, and the endocrine shock. So let's see the different clinical consequences of the shock. So because of the shock, it can be possibilities that because of the increased blood loss or a prolonged shock, it will result in the possibility of the unresuscitable shock. Due to prolonged shock for a prolonged time, there is a formation of the increased loss of the blood volume, ultimately lead to the unresuscitable state. There is a cellular hypoxia and the ischemia and ultimately lead to the cell death. So because if there is this effect occur at the level of the heart, there is a myocardial cell death due to the ischemia, and there is a myocardial depression, which is the ultimate result of the severe acidemia and the hyperkalemia, which causes myocardial depression, which ultimately lead to the decreased cardiac output, decreased response to the fluid and the inotropic therapy. Because of this, peripheries become resistant to the vasopressor agent, that is adrenaline, noradrenaline, and in this case the death is inevitable. So this can be the possibility of the shock, the unresuscitable shock state. So because the another consequences is that there is a ischemia reperfusion injury. So because of the shock, there is a formation of the multiple cellular metabolites at the level of the cell, and so because of the resuscitation, we give fluid, blood, and these metabolites which are accumulated at the cellular level, they came into the systemic circulation and ultimately forms this toxic metabolite causes their toxicity in different organ and lead to the multiple organ dysfunction. So during the shock state, there is a organ damage due to direct hypoxia and the local inflammation, ultimately lead to the hyperkalemia, acidosis, and increased toxic metabolite. After resuscitation, these metabolite comes into the systemic circulation, which damage the organ. So damage to the heart will lead to the myocardial depression, vasodilatation, or a hypotension. So injury to the lung, which causes ARDS, that is acute respiratory distress syndrome. Injury to the kidney causes acute renal failure, and injury to the liver lead to the coagulopathy, the liver failure. This metabolites also damage to the brain, and which causes the cerebral swelling and the dysfunction, and ultimately lead to the death. So this is the reperfusion injury, and this can be prevented by reducing the extent and the duration of the tissue hypoperfusion. So this can be prevented by treating the patient as early as possible by reducing the extent and the duration of the tissue hypoperfusion. So ultimately, the next effect can be systemic inflammatory response syndrome and the multiple organ failure. So what is systemic inflammatory response syndrome? So it is a body's own response to the shock. So ultimately it forms the, it can be systemic inflammatory response can be defined as a fever, heart rate more than 90 beats per minute, respiratory rate more than 20 breaths per minute, or a PaCO2 less than 32 mmHg, or there is a TLC count more than 12,000, or it can be less than 4,000, or there is a immature or band form cells are more than 10%. So SRS is defined as presence of any two or more than two of these features. So presence of two or more than these features suggests of the systemic inflammatory response syndrome. So remember, fever more than 38 degrees Celsius, heart rate more than 90 beats per minute, respiratory rate more than 20, or PaCO2 less than 32 mmHg, or a TLC, raised TLC more than 12,000, or decrease in the TLC less than 4,000, or more than 10% of the band form. So presence of two or more than two, these features considered as a systemic inflammatory response syndrome. So what is multiple organ dysfunction syndrome, that is MODS? So it is a clinical syndrome characterized by the development of progressive and potentially reversible physiological dysfunction in two or more organs. Remember that two or more organs are involved. It is induced by the variety of the acute insult, including the sepsis, and the mortality in case of the multiple organ dysfunction syndrome is more than 60%. So these are the clinical consequences of the shock. It can be unresuscitable shock, or can be reperfusion injury, or systemic inflammatory response syndrome, or a multiple organ dysfunction syndrome. So this is about the pathophysiology behind the. So let's learn this very important charts given in the alien law, which differentiate the different types of the shock, and it states the different or specific features related to the different types of the shock. So basically remember that there are four types of shock: hypovolemic shock, cardiogenic shock, obstructive shock, and the distributive shock. So what are the effect of on the cardiac output? So it is a state of a shock. So remember that in all shock the cardiac output is decreased except the distributive shock. So remember that in case of a distributive shock, the cardiac output is actually increased because the blood is accumulated at the vascular level. The body senses that there is a state of shock and tries to increase the cardiac output by activation of the sympathetic system, and because the blood is at the level of the vascular level, there is an increase in the preload, which ultimately lead to the increased cardiac output. So the problem is not at the level of the heart or at the level of the volume of the blood. Problem is at the distribution. So the body senses that the blood is decreased at the level of cell, so tries to increase the cardiac output with a compensatory mechanism. So remember that in all shock the cardiac output is decreased except in the distributive shock, the septic shock. So the same is for that systemic vascular resistant. So because of the hypovolemia or cardiogenic shock, the body tries to decrease blood at the non-vital organ, tries to increase blood to the vital structures by distribution of the blood. So it will lead to causes of the vasoconstriction at the peripheries and divert the blood to the vital organ like heart, kidney, brain, liver, and try to compensate the organ failure by increasing the vascular resistance. So systemic vascular resistance is high at the in all shock except the septic shock, that is distributive shock. The basic pathophysiology at the of septic shock is at the systemic vascular resistance, that is decrease in the systemic vascular resistance because of the vasodilatation. So the systemic vascular resistance is high in all shock except the distributed shock. And same is for the venous pressure. So venous pressure is decreased in case of the septic or distributive shock and the hypovolemic shock. Why the venous pressure is decreased in hypovolemic shock? Because the volume is lost. There is a lost volume, so the pressure is decreased. In cardiogenic shock and the obstructive shock, there is a volume is normal, there is a systemic vasoconstriction. So there is a double effect. The volume is normal and there is a vasoconstriction. So the venous pressure is increased. But in case of a hypovolemic shock, despite that the systemic vascular resistance is increased, but the actual volume is decreased. So there is a decrease in the venous pressure. Remember that venous pressure is decreased in hypovolemic shock because of the hypovolemia, and the decrease in case of a distributive shock, this is because of the vasodilatation. So the cause for the decreased venous pressure is different in both the shock. In hypovolemic shock, it is due to volume loss, and in case of a distributive shock, it is because of the vasodilatation. So another important feature to distinguish the shock, that is mixed venous saturation or a mixed venous oxygen saturation. So in all type of shock, the mixed venous saturation is decreased, that is low or less than 50%, but it is high in case of a distributive shock. So it is a diagnostic criteria for the distributive shock or a septic shock. It is MVOS more than 70% is the diagnostic of a distributive shock or a septic shock. So let's learn why the MVOS is increased in case of a septic shock and it is decreased in case of a other type of. So what is MVOS? It is a mixed venous oxygen saturation. So the highest oxygen saturation, consider it is in the heart. The heart pumps the blood with highest oxygen saturation, goes to the tissue level, and at the tissue level the oxygen is distributed to the cells and the tissue, and the deoxygenated blood comes into the capillaries, and the deoxygenated blood returns to the heart. So the venous system contains the deoxygenated blood. So because in case of the cardiogenic shock or hypovolemic shock, there is an increased demand at the tissue level of the oxygen and the glucose. There is a increased utilization of the oxygen by the tissues, but and the flow or the oxygen saturation will be low in case of a blood in the venous system. So there is a decreased mixed venous oxygen saturation in case of a other type of shock. But in case of a septic shock or a distributive shock, there is a problem in the utilization of the that blood or a distribution of the oxygen at the cellular level. So the blood comes unutilized back into the heart. So the mixed venous oxygen saturation would be the increased as compared to the other type of shock in case of a septic shock. So that's why the MVOS is increased in case of a septic shock or a distributive shock, and it is a diagnostic criteria for a septic shock. So MVOS would be more than 70% in case of a distributive shock. MVOS is decreased in all type of shock except the distributive shock. So base deficit. So ultimately the base deficit is because of the deficit of the base is because of the increase in the acidosis, because of the lactic acidosis. So base deficit would be the high in all type of the shock. So how would be the effect on the extremities? In case of a hypovolemic shock, because of the vasoconstriction, there is a extremities become cold, and in case of a distributive shock, because of the vasodilatation, extremities become warm. Extremities become warm. So the septic shock or distributive shock can be called as a warm type of shock. So, and there is a capillary refill time. So the capillary refill time is increased in all type of shock except in case of a distributive shock. Is the actually blood at the level of the tissue is high. So the capillary refill time is reduced in case of a distributive shock, but it is a prolonged in case of a other type of a shock, because there is a not decreased blood volume at the cellular level in septic shock. The blood volume at the cellular level is normal. The problem is that the utilization of the available blood. So capillary refill at the distributive shock is a increase or a brisk, or a capillary refill is decrease. In the other type of shock, the capillary refill is increase or a prolonged. So that's all about the pathophysiology of the shock. So let's revise. We have seen the pathophysiology of the shock at the cellular level. The ultimate effect of the shock at the cellular level is a hyperkalemia, hyponatremia, and hypocalcemia. So the pathophysiology of the microvascular level, because of the hypoxia and acidosis, will ultimately result in the endothelial gap junction formation and the tissue edema, and ultimately increases the cellular hypoxia. And we have seen the systemic manifestation of the shock at the different system, and also seen their exceptions. So we have seen the different types of the types of the shock: hypovolemic shock, cardiogenic shock, obstructive shock, distributive shock, and the endocrine shock. And we have already seen the consequences of the shock, and we have seen the systemic inflammatory response syndrome and the multiple organ dysfunction syndrome, and we have seen the different characteristic of this different shock. So remember that the cardiac output is decreased in all type of shock except the septic or distributive shock. There is a mixed venous saturation is decreased in all type of shock, but it is high, is more than 70 in case of a septic shock or distributive shock. Capillary refill time is prolonged in other type of shock except in the septic shock, in which it is a brisk, or a capillary refill time is reduced. So this is all about the pathophysiology of the shock. In next topic we will see the first class of the shock, that is hypovolemic shock. So thank you so much.